Alcoholic liver disease refers to the morbidity and mortality resulting from the consumption of excessive amounts of alcohol. This is a very costly condition because it affects so many people, not only those who are actually abusing the alcohol, but also the people around them. There are 3 types of ALD we will be talking about in this lecture, including fatty liver, alcoholic hepatitis, and cirrhosis. We do want to point out that fatty liver and cirrhosis could occur without alcohol. For example, we've mentioned in the previous part of this lecture that hepatitis B could lead to cirrhosis. Fatty liver refers to abnormal accumulation of triglycerides in the liver. We know that the liver is very active in lipid metabolism. It breaks down and synthesizes a lot of triglycerides. Under normal conditions, triglycerides are synthesized in the liver, and then they are sent out to other parts of the body on VLDL, the very low density lipoprotein particles. If there's any imbalance in this process, when we have more triglycerides synthesized in the liver than what the liver can transport out, then fat will accumulate in the liver. This leads to fatty liver. We just mentioned that this could happen as the result of long-term alcohol abuse, or it could happen in the absence of alcohol consumption. There are many other conditions that can trigger or promote fatty liver development. Usually, fatty liver does not cause any symptoms. Many people actually find out that they have fatty liver when they are doing an ultrasound, but they didn't really feel any symptoms themselves. So the good thing about fatty liver is that it is a reversible condition. If we have accumulation of the fat in the liver, through proper interventions, including diet and exercise, this condition can be reversed. So this is a good thing, and this is a reason why we need to help promote behavior change and lifestyle change for these individuals. Alcoholic hepatitis refers to the inflammation in the liver caused by long-term alcohol abuse. So the damage is caused without viral infection. Although when people have this hepatitis caused by alcohol, they are more vulnerable to have infections, partially because our liver makes a lot of proteins that contribute to our immune function. So damage to the liver in this capacity could affect our defense system. People with alcoholic hepatitis usually complain about fatigue, weakness, and loss of appetite. And we know that loss of appetite is very common for people who have a drinking problem. You know, they could be drinking 50% of total calories, but they don't want to eat a real meal. So in severe cases, they may have liver damage and other conditions. So we can see here that the shape of the liver is already damaged. And this is because alcoholic hepatitis could move on to lead to cirrhosis. But before we talk about cirrhosis, let's talk about the intervention for alcoholic liver disease. We already explained with chronic alcohol abuse, people are more likely to have an imbalanced diet. You know, we mentioned that they are consuming potentially 50% of their calories as alcohol, and this is, of course, a form of empty calories. They have a very low appetite for whole food or a real meal. So as a result, due to the liver's key function in metabolism, this may factor in digestion and absorption. And alcohol increases nutrient turnover as well. On top of that, people will be at risk for deficiency of many micronutrients. So we should be checking weight and weight history, physical assessment. Again, for people with this long-term problem, they usually have signs for malnutrition. Of course, dietary intake is absolutely necessary to assess. And for lifestyle factors, we particularly want to ask about drinking habits. What are they drinking? How much? How frequently? What settings? Who they're drinking with? Things like that. And also we'll want to know if they're using any supplements. Common problems for a nutrition diagnosis are listed here. With this condition, with inflammation, high energy expenditure is higher than usual. But this exacerbates the imbalance between intake and the requirement. Therefore, we have a lot of problems in the domain of inadequate intake. Malnutrition, again, is not uncommon, and impaired utilization for sure is valid in this condition. Also, having the patient be underweight is common. So all of these are associated with the consequence of long-term alcohol abuse. The number one nutrition intervention in this population is to avoid alcohol. We really don't want them to consume alcohol to further damage the liver. Also, we want to provide adequate nutrient and energy for the liver to regenerate, although in most cases, this regeneration will not be complete. But getting something regenerated is better than nothing. We need to measure and monitor specific outcomes, for example, food intake, alcohol consumption. We would hope that that goes down to 0, of course. And any weight gain, that would be good. So any improvement for involuntary weight loss or signs associated with malnutrition we'll want to be monitoring. Usually people who have this condition do not have adequate dietary intake on top of increased nutrient turnover. So very often we need to provide additional supplements to these individuals. This list summarizes the main vitamin and mineral supplements we would normally give to people who have drinking problems. Actually, in severe cases, if the patients are in the hospital or checked into a rehab clinic, they may get IV delivery of a large quantity of these micronutrients as an initial correction, because usually their nutrition status it's quite miserable upon admission. So we would want to have some quick fix with the IV delivery and then go for a longer term intervention from there. So as we mentioned, cirrhosis is a condition that could be caused by alcoholism or a viral infection. It may be clinically silent, meaning that the patient may not feel anything or may not feel anything specific to make them suspect that they have cirrhosis. If we're talking about cirrhosis caused by alcohol, we definitely want to avoid alcohol once we find out this condition exists. This in itself, actually, just stopping drinking alcohol, could stop the disease. Although, unfortunately, the change in anatomy caused by cirrhosis is irreversible. But at least by stopping the drinking of alcohol, we can help the individual to stop further damage to the liver by the alcohol. Then certain functions can improve once the alcohol is taken out of the picture. So this table lists the common causes of cirrhosis and other not so common causes. So we can see that viral infection and alcohol consumption are not the only two reasons for cirrhosis, but they are the most common. So in cirrhosis, people generally have general symptoms that are not very specific. For example, feeling tired, weak, having nausea, poor appetite, lack of energy. All of these are not specific to liver conditions, but in certain cases, we will have liver-specific symptoms. that are listed here. So for example, we talked about jaundice, the yellowing tint in the skin and in the white of the eye, and also the darker urine. Also, the stool may change color as well, especially if the flow of bile to the small intestine is blocked for one reason or another. The accumulation of bilirubin and jaundice in the skin could actually cause itching. So if we're talking about kids, and we're hoping that it's not common for kids to have alcohol disease, but if they do have jaundice, that could lead to itchy skin for them. Then in severe cases, they could, of course, have ascites. And vitamin and mineral deficiencies are very common. And major clinical complications, as we mentioned, it could lead to portal hypertension. In cirrhosis, the liver tissue is damaged and permanently altered. So the change in the anatomy of the structure inside the liver could lead to abnormal blood pressure in the portal system, which of course would push everything down towards the GI veins, and we may have varices and then bleeding from these varices. So due to the damage of liver function, we may have hepatic encephalopathy, the accumulation of too much ammonia. This hurts the brain and the nervous system. We may see accumulation of fluid in the abdominal cavity, the ascites, as we mentioned, and again, bleeding that could lead to really severe consequences with the varices. Here again, looking at the cirrhosis, we can see in this case, we definitely see the surface. We have all these abnormal nodes compared to the normal surface, the smooth surface of the liver. In this case, in the cirrhosis liver, we see at least the shape of the liver still maintains, although we can definitely tell that something is wrong. Right? We can still see all those nodes on the surface. However, in reality, many people with cirrhosis, their liver no longer has a recognizable shape. So the damage to the anatomy could be that bad that the liver doesn't even look like the shape of a liver. To treat cirrhosis, we definitely need to take alcohol out of the picture to stop further damage. Then we will also have to treat any potential complications. Again, unfortunately, cirrhosis is irreversible. We can only maintain the function we have left. We cannot reverse the damage. So we would want to be retaining the remaining function for as long as possible. So in cirrhosis, it's common to have ascites, and early satiety is very common for patients with ascites. If we recall that picture where we saw the distended abdomen, it pushed the diaphragm upwards, so therefore they don't really have a good appetite. Also, think about the fluid pressure on the intestine, on the stomach, in the abdominal cavity. People would be feeling full very early, not to mention having a decreased appetite to begin with. So many reasons in this case can contribute to decreased oral intake. We will also see impaired digestion and absorption, and also increased energy expenditure. Hypoglycemia is occurring because with the damage to the liver, we will have few, if any, glycogen molecules stored, so our ability to store glycogen is decreased. And at the same time, if we are reaching end stage, then they may have developed diabetes, and that's when we would be detecting hyperglycemia. For nutrition assessment, in addition to the usual assessment, we need to check lifestyle factors for sure, including alcohol, because this is the main concern that will lead to further damage of the liver. And we also have to pay attention to potential nutrient deficiencies and definitely check the medical history. Cirrhosis, because it is irreversible, It is a long-term chronic condition, so the medication or other prevention will have to be received on the long-term basis. And it could change over time due to the severity of complications and other factors. So we need to be checking to make sure that if there's a new impact or interaction, with a nutrient or nutrition, we as dietitians need to be aware of those. In addition to the problems we explained in fatty liver caused by alcoholism and cirrhosis, we may also see certain problems associated with complications of cirrhosis. We mentioned those complications, for example, hypoglycemia, hyperglycemia, depending on which state we're talking about. And as we mentioned, early satiety caused by ascites, or even GI bleeding caused by the varices resulting from the portal hypertension. For energy and nutrient needs, we should not restrict protein. However, we do need to pay attention to the type of protein because people with cirrhosis are at high risk to develop hepatic encephalopathy. Although they're malnourished, the liver also has limited capacity, so we want to give adequate amount of high-quality protein. We don't want to be providing too much aromatic amino acids because this would lead to the increased ammonia level in the system and encephalopathy. We shouldn't restrict the amount of protein, but we want to pay attention to the type of protein we provide. And of course, if they reach a stage of diabetes, the end stage, obviously we need to execute carbohydrate restriction. In that case, what we learned in diabetes will apply. If the patient has ascites, sodium restriction will be indicated. Also, and this is because, it's fluid retention, so that's why there would be the sodium restriction. And for other considerations, we may want to consider enteral feeding in certain cases, if they couldn't be taking adequate oral intake for a long period of time. Also, we want to make sure the texture of the diet is soft, especially for patients with varices. So we already mentioned that this is a condition with enlarged GI veins due to portal hypertension. And if we have hard or sharp texture of food consumed, this could literally cause the bleeding of the veins with the varices, so the hard food rubbing against those enlarged GI veins could cause bleeding. If we consider this, the result of varices, it's being caused by portal hypertension, and therefore if the GI veins break, we have the hypertension in the portal vein pushing a lot of blood out of the system. So the bleeding is fast, quick, and can be fatal in many cases. Therefore, we really want to prevent this from happening because the patients may not even have time to get to the ER in certain cases. We need to monitor the tolerance to different types of feedings and amount of nutrients consumed. And we need to pay attention to dry weight changes because with ascites, the weight is of course affected by fluid retention. So we really want to investigate further exactly what the dry weight is without the fluid. This would be helpful for us determining our dosing weights. And lab values and cognitive status, again, we want to monitor if there is hepatic encephalopathy. In this case, I want to mention you may see when doctors treat patients with this condition, if they have GI bleeding caused by varices and the patient survives, doctors may give them a laxative to make sure they have a bowel movement. So the reason for this is that, if we think about it, whole blood has a lot of protein in it, not to mention the hemoglobin, but also plasma proteins. So if we have GI bleeding, that means in the lumen of the GI, we're going to be having a high presence of protein. So then a short period of time, these proteins will be digested, amino acids will be absorbed and sent to the liver. But remember, our liver is impaired, so this could overwhelm the liver. It's already got issues functioning already, and it may not be able to deal with the nitrogenous waste, so therefore we'll see the accumulation of ammonia, and this may be exacerbated. Therefore, a lot of patients with cirrhosis, they can pass into a coma after GI bleeding. Although, we had the bleeding under control, they still may pass into a coma due to encephalopathy from the absorption of the amino acids that was in the blood that leaked into the lumen. So this is something you'll see in practice, and you understand that what we're trying to do is increase the bowel movement so that the protein from the whole blood can be disposed of within the feces and not necessarily absorbed back into the body.